Okay. We are about
Yes,
to
hello.
hello. We are about to start the webinar. Okay. Welcome to Dandelion series webinar, Meet with Expert in Regional Anesthesia. This is Jensen from Visani Medical. Nice to meet you. Today, we are so proud to invite our friends, Dr. Pen and Professor Kessler, to be our presenter today. Let's take a look at the subjects today. Okay. Professor Kessler will present updates pediatric regional anesthesia. Welcome. Hello.
Yes,
Professor Kessler.
hello.
Good afternoon.
Good afternoon. Good afternoon.
And Dr. Pen will present updates on facial plan block for breast surgery anesthesia. Good evening, Dr. Pen.
Good evening.
Okay. Firstly, I will introduce Dr. Pen. Dr. Penafancia Cano is currently session head and associate professor of the Department of Anesthesiology, University of Philippine General Hospital. She is board certified in anesthesiology and received specialty training at University of Philippines. As current vice president of Philippine Society of Anesthesiologists, Dr. Pen is devoted to educational research and scientific activity. She has joined more than 100 academic activity in anesthesiology. She is also the member of many international societies. From 1993 to 2001, Dr. Pen was associate professor at Department of Biochemistry and Molecular Biology, University of Philippines. From 2001 to 2008, she was session chief of ambulatory anesthesia department of anesthesiology, University of Philippines. From 2008 to 2017, she was session chief of orthopedic anesthesia at Department of Anesthesiology and Philippine General Hospital. And then I will introduce Professor Paul Kessler. Professor Paul Kessler is current chair of the Department of Anesthesiology, Intensive Care Medicine and Paramedicine of Orthopedic University Clinic in Frankfurt, Germany. He received his specialty in anesthesiology at Johann Wolfgang Goethe University, Frankfurt, Germany. He is board certified in anesthesiology, critical care medicine, pain therapy, and emergency medicine, and was awarded proficiency in anesthesiology in 1998. His clinical expertise focuses on regional anesthesia. Professor Kessler has co-authored over 100 review papers, renewed articles, case reports, book chapters. From 2009 to 2014, he was chairman of German Task Force of Regional Anesthesia. From 2009 to 2013, he was board member of ESRA. From 2014 to 2018, he was the German joint representative in ESRA Council. Okay, and now let's welcome Dr. Pen to share the experience first.
Okay, good evening, everyone. So now let me share my screen. Thank you for the nice introduction, Jensen. Okay. The topic for tonight is on updates of facial plane blocks for breast surgery analgesia. When it comes to analgesia for breast surgery, we have known that paravertebral block is the gold standard for postoperative pain management. But a lot of anesthesiologists would try to shy away from doing this technique because it's pleural puncture pneumothorax and it has a failure rate of 6.1%. Before we proceed, let us first have a brief review of the anatomy of the breast. The breast is essentially a subcutaneous organ. It is innervated medially by the anterior cutaneous branches and laterally by the lateral cutaneous branches of the intercostal nerve, with minor contributions from the supraclavicular nerves. Now, the T2 lateral cutaneous branch, which is more popularly known as the intercostobrachial nerve, would provide sensory innervation to the axillary tail of the breast, as well as that of the axilla. This nerve is an important nerve that we should block for axillary lymph node dissection and also sentinel lymph node dissection. The pectoral muscles, on the other hand, are innervated by branches from the brachial plexus. The lateral pectoral nerve would provide innervation to the upper portion of the pectoralis major muscle, while the medial pectoral nerve would pierce the pectoralis minor, and it would proceed anteriorly and innervate the lower portion of the pectoralis major muscle. When it comes to the lateral wall, the serratus anterior muscle would be innervated by the long thoracic nerve, whereas the thoracodorsal nerve would innervate the latissimus dorsi muscle. Before we proceed, let us first try to know what a fascia is. A fascia is a complex, collagenous, fibrous connective tissue that encloses the muscles and separates them from other structures like the blood vessels and the nerves. There are actually two types of fascia. The first is the superficial, which is a layer of loose connective tissue that supports the subcutaneous structure, which is shown here in this picture. While the deep type of fascia is a fibrous structure that sheaths the muscle, and this is the target for the fascial plain blocks. Now, according to the paper that was written by Black and colleagues, there are many characteristics of the deep fascia that may influence the extent of the spread and clinical effectiveness of the local anesthetic, and this may be a cause of block inconsistency. The deep fascia actually has two subtypes. The first type is the epimysial, which is thinner and adherent to the muscles. Typical example is the pecs, which can be shown here. We have here the epimysial layer, which is very thin, which is attached to pectoralis major muscle. Another typical example is the serratus anterior plane and the top, while the aponeurotic layer is a thicker, which is a thicker sheath, which is easily separable from the muscles. The typical example would be the thoracolumbar fascia, which is seen here in this picture. You also have the quadratus lumborum, the rectus sheath, the ESP, the ductal canal, and the fascia iliaca. Now, these characters of the fascia may affect the spread of the local anesthetic because a thicker aponeurotic fascial plane may represent a greater physical barrier to the local anesthetic diffusion, while a thin epimysial layer might make this diffusion easier. Alternatively, a thicker layer may provide a more distinct sonographic endpoint for injection and keep the local anesthetic within the facial plane, allowing for a greater spread, while it may be more difficult to inject the local anesthetic within the epimysial layer, because with the thin layer, the local anesthetic might spill to the perimysium and enter the muscle, thus resulting in a lesser anesthetic effect. The second factor that Black presented are the lines of fusion, which he says they are sites where the fascia would fuse and can limit the spread of the local anesthetic. Now, the third factor is the fascial interconnectivity. There are fascial planes that are continuous without a clear anatomical boundary. One typical example is the thoracolumbar fascia, which is shown here, which can extend as far as the endothoracic fascia in the thorax. Some studies have shown that if the paravertebral space, in the thorax, and this is all because of fascial interconnectivity. Now, the viscosity and the quantity of the hyaluronic acid may also affect the spread of the local anesthetic, because if there is less viscosity and quantity of the hyaluronic acid, there will be less fascial gliding. Now, the presence of the nerves, whether somatic and sympathetic, and the nerves in the fascia, may also affect the spread of the local anesthetic. If the patient had a systemic illness and there will be a lesser amount of the nerves, then there will be a lesser effect of the local anesthetic. It was Dr. Rafael Blanco who first introduced the 3 novel interfascial analgesia techniques that would provide almost similar analgesia as the paravertebral block through simple techniques with a lower risk of adverse events. They're considered as safer alternatives with the paravertebral block. The blocks that Blanco introduced are the Pecs 1, Pecs 2, and the Serratus plane block, which are called the anterolateral wall blocks. As a review, Pecs 1 refers to the injection of the local anesthetic between the pectoralis major and minor muscle. This is effective for blocks that affects the pectoral muscles and also the fascia. Like, for example, insertion of the portacat and also for breast augmentation. Now, when it comes to the Pecs 2, it refers to the injection of the local anesthetic, either anterior to the serratus anterior muscle or deep to the serratus anterior muscle. It can be injected either in the 3rd or in the 4th rib. This is in conjunction with the injection between the pectoralis major and minor muscle. So if the Pecs 1 would target the lateral and medial pectoral nerve, in addition to that, for the Pecs 2, we can also block the intercostobrachial nerve, the long thoracic nerve, the lateral cutaneous branches of the intercostal nerve from T2 to T4, which can extend as far as up to T6. Now, how can we differentiate the Pecs 2 from the paravertebral block? Based from the meta-analysis that was performed by Versick and also by Hussein, among those patients who underwent breast surgery, either with or without axillary lymph node dissection, Pecs 2 is superior to systemic analgesia, but it is similar and not inferior to paravertebral block. Tauschen also conducted a meta-analysis differentiating the Pecs 2 block from the paravertebral block, and he was able to conclude that there's no significant difference in 24 hours opioid consumption. There's also no significant difference in the time to rescue analgesia between the 2 blocks, and then further studies are unlikely to alter the conclusion, which means that the Pecs 2 block would deliver the same analgesia as the paravertebral block. In this meta-analysis, they were also able to record 2 cases of pneumothorax and 1 case of unintentional bilateral block with the paravertebral. The 3rd block that Blanco introduced is the Serratus plane block, which aims to provide or to further extend intercostal analgesia. This refers to the injection of the local anesthetic either superficial or deep to the serratus anterior muscle, either at rib 4 or rib 5. It can block the lateral cutaneous branches up to T9, including the axilla and a portion of the back. Now, the Serratus plane block is not only effective for breast surgeries, but it can also be effective for the latissimus dorsi flap, chest drain insertion, rib fractures, and thoracic surgery. Based from the study that was conducted by Abdallah, where they tried to differentiate the effect of the local anesthetic, whether it is injected superficial or deep to the serratus anterior muscle, their findings showed that the deep serratus block were non-inferior to those of the superficial serratus block in terms of postoperative morphine consumption to the injection of the local anesthetic, either superficial or deep to the serratus anterior muscle, and the site of injection and the extent of the injectate spread. This was done by the group of Vincent Chan and colleagues. The dye spread, according to their findings, is influenced by the volume rather than the plane of injection, which means that it doesn't matter if you inject the local anesthetic either superficial or deep to the serratus anterior muscle. The injection at the fifth rib, which is one level, as compared to two levels, which is at the fifth and the third rib, with a volume of 20 versus 40 mils, would also double the area of injectate spread from 4 levels to 7 levels. The spread to the axilla is most consistent if injection is done at the third rib. We were also able to observe that preferential spread was more at the anterior chest wall with little cephalad to caudate, but there was no posterior spread. Based from this illustration, we can see that when the local or the dye was injected at the rib level 5, whether it was done at the superficial or deep to the serratus anterior muscle, we can see that there was spread of the local anesthetic or the dye from T3 to T6. But with the two-level injection, with the injection at rib 3 and rib 5, there was a wider spread both for the superficial and deep injection. It was seen here, it can be seen here that there was a spread from T1 to T7. We can therefore conclude that there's really no difference, as I have mentioned earlier, whether you inject the local anesthetic, superficial or deep to the serratus plane, but we can also see here that if you do a multi-level technique with a greater volume of the local anesthetic, there will also be a wider spread of the local anesthetic. Now, Rosek and colleagues performed a study where they tried to differentiate the effect of the SPB from the Pecs block. And their findings showed that the duration of the sensory block was longer for the SPB, and the dermatomal level of sensory block was also wider as compared to the Pecs block. The VAS score at rest and movement when the patients who received postoperative fentanyl was also significantly lower for the SPB. When it comes to the first request for postoperative fentanyl, it was significantly delayed for the SPB, while there was no total dose consumption for the postoperative fentanyl for both blocks. As a conclusion, the Pecs and the SPB block would produce excellent analgesia, but the SPB provided a more superior analgesia as compared to the Pecs 2 block. On the contrary, based on the randomized controlled trial that was performed by Bakir and colleagues among more than 180 adult female patients who had breast surgery, they were able to conclude that the SPB and the Pecs block were superior to systemic analgesia in terms of postoperative morphine requirement, intraoperative fentanyl consumption, and time to first rescue analgesia. They were also able to conclude that there's really no significant difference between the SPB and Pecs for all the parameters. Now, this is in contrary to the previous study, which showed that SPB was superior to the Pecs 2 block in terms of analgesic efficacy. It is therefore needed that more studies should be done in order to verify which technique is really much better. Would it be the Pecs 2 block or the SPB? Now, when it comes to SPB being compared to the paravertebral block, Hetham in his study showed that the 24-hour morphine consumption for the paravertebral block was significantly lower as compared to the SPB, whereas the median postoperative time to first analgesic request was significantly lower for the PVB as compared to the Serratus plain block. They were able to conclude that SPB or the Serratus plain block is inferior to the paravertebral block for post-mastectomy pain. the PCA morphine consumption was significantly lower for the paravertebral block. So they were able to conclude that the paravertebral block had a longer duration of analgesia and lower morphine consumption as compared to the Serratus pain block. I made a mistake earlier. So it's Serratus pain block, not Pecs 2 block. So based from the two studies that were done, they were able to conclude that paravertebral block is significantly better as compared to the Serratus pain block. The blocks that Blanco introduced would block all those nerves that provide innervation to the lateral portion of the breast, while the medial portion, which is innervated by the anterior cutaneous branches of the intercostal nerve, can be blocked by this technique, which Ueshima introduced. He called it as the transversus thoracic muscle plane block. It refers to the injection of the local anesthetic between the transversus thoracic muscle and the internal intercostal muscle. He would inject it between the rib 3 and rib 4, which he said would have an effect from T2 to T6. Based from his study, he was able to show that if you would combine the Pecs 2 with a TTM block, there will be a lower VAS score as compared to performing a Pecs 2 alone. Murata, however, was able to record several difficulties in the performance of this block. He said that transversus thoracic muscle plane block is very thin, that sometimes it is hard to discern this muscle. Aside from that, the point of injection is also very near the pleura, and there are also a lot of vessels that have to be traversed at the site of injection. As an answer to this problem, Bushi introduced the parasternal intercostal nerve block, while De La Torre introduced the pecto-intercostal fascial plane block. They are of different names, but it actually means only to the same injection, which is putting the local anesthetic in between the internal intercostal muscle and the pectoralis major muscle. The effect will be the same because the anterior cutaneous branch of the intercostal nerve would pass along the transversus thoracic muscle to pierce the internal intercostal muscle and the pectoralis major muscle. Now go to the paraspinal blocks. The rector spinae plane block refers to the injection of the local anesthetic between the transverse process and the erector spinae muscles. They are in close proximity to the costotransverse foramen, where both the dorsal and the ventral rami would emanate, and thus it is sure that the ventral and the dorsal rami will be blocked by this technique. Another very similar paraspinal block to the ESP is the retrolaminar block, which involves injection of the local anesthetic between the lamina and the transversus spinalis muscle. Compared to the erector spinae block, the injection is more medial and it is also more deeper. Now, the muscle layer over the lamina is a thick group of muscles that are composed of 3 muscles, which is collectively known as the transversus spinalis muscle. And on top of this transversus spinalis muscle are the erector spinae group of muscles. These differences can conceivably result in a different pattern of local anesthetic spread. You can see here in this illustration that the transversus spinalis muscle are located in the lamina between the spinous process and the transverse process. So they are very deeply situated, whereas the erector spinae group of muscles are more superficially located and they lie on top of the transversus spinalis muscle. Based on the cadaveric dissection that was done by Adhikari, he was able to show that the spread of the dye at the retrolaminar area was mainly between the spinous process and the transverse process, whereas the spread of the dye for the erector spinae was craniocaudal, and in addition to that, there was also a lax to line levels. Whereas for the lateral spread to the intercostal spaces, for all of the cadavers, actually there were only 3 cadavers, but for all of the cadavers, there was lateral spread which spanned around 10 to 11 centimeters from the midline, ranging from 6 to 9 levels. Whereas for the retrolaminar block, it was only in 1 cadaver where there was a lateral spread, and it was only at 1 level, which was at T6. When it comes to the MRI imaging, they were able to observe that for the retrolaminar block, the spread was only contained within the transverse spinalis muscle, whereas for the erector spinae muscle, for the erector spinae plane block, they was spread to the muscle, the erector spinae muscle, but there was also spread, lateral spread to the intercostal spaces. For both blocks, there was also epidural and neural foramina spread. Now, when it comes to the spread to the epidural space, it spanned 5 spaces, and it was very constant for the retrolaminar block, whereas for the ESP, it spanned only from 2 to 5 spaces. When it comes to the neural foramina spread, it spanned for 3 to 6 spaces for the retrolaminar block, whereas for the ESP, it spanned from 2 to 3 spaces. This provides the basis for somatic and visceral analgesia. This demonstrates that injectate spreads beyond the paravertebral space. In another cadaveric study that was done by Young and colleagues, they had the same findings as that of the previous study, wherein there was lateral spread of the ESP aside from the craniocaudal spread, whereas for the retrolaminar block, there was only craniocaudal spread, and there was no observed lateral spread. But based on their findings for both blocks, they were able to observe spread in the superior costotransverse ligament and also the paravertebral space, and also the intercostal nerves from T4 to T6. This is a summary of their findings. Again, there was only vertical spread with the retrolaminar block, and the spread for the erector spinae was more lateral aside from the craniocaudal or vertical spread. There was spread for both blocks to the superior costotransverse ligament and also to the T4 and T6 intercostal spaces. Whereas there was a more spinal nerve involvement with the erector spinae with a median of 3.5, whereas there was only a spinal nerve involvement of 2 for the retrolaminar block. Now, the studies that I mentioned referred to cadaveric dissections wherein there were paravertebral spread. But contrary to those studies, there were also studies that did not show any paravertebral spread. And they are those studies by Ivanosic and Aponte. Based on the randomized clinical trial of Yavuz Gurkan, wherein he tried to differentiate the effect of the ESP from the thoracic paravertebral block, his findings showed that the ESP and the paravertebral block were significantly different or much better from the control group, while there was no significant difference between the ESP and the paravertebral group. Based on the systematic review and meta-analysis that was conducted by Leong and colleagues, where he compared the ESP from systemic analgesia along with the paravertebral and the Pecs block, he was able to show that there was a lower pain score with the ESP as compared to the control group, whereas the efficacy of the ESP is similar to paravertebral block, but surprisingly, the meta-analysis that we performed showed that the ESP is inferior to the Pecs block. Further evidence is needed to confirm these findings. Based from the cadaveric dissection by Saburi, wherein he tried to investigate also the spread of the local anesthetic or the dye for the retrolaminar block, he had the same findings as Yang, wherein there was paravertebral spread. There was also spread to the epidural space, the intervertebral foramina for the paravertebral block. The postoperative fentanyl dose was not significant between the two groups, whereas the frequency of rescue use within the 24 hours was significantly lower for the paravertebral block, whereas the opioid use for 24 hours, there was no need for, or there was no demand for either blocks. They were able to conclude that except for the first 24 hours, the continuous retrolaminar block was not inferior to the paravertebral block. Chapter also did a continuous retrolaminar block to try to investigate the analgesic efficacy of this technique. Based on his finding, there was no additional opioids required during surgery. No opioids were also required postoperatively up to the 72nd hour. He was able to conclude that the continuous retrolaminar block is an effective technique for intraoperative and postoperative analgesia in patients undergoing mastectomy with or without axillary lymph node dissection. Now, this is in contrary to a single-shot retrolaminar block, because based on the study by Wang, he was able to conclude that there was no significant difference between the control and the single-shot retrolaminar block. Onishi, on the other hand, did a double-level single-shot retrolaminar block, and his findings showed that the retrolaminar block was significantly had a time to first analgesia that was significantly longer, which is around 161 minutes versus 64 minutes, which is a difference of around 2 hours as compared to the control group. The pain score immediately after surgery was significantly lower for the retrolaminar block, but within the 12-hour period, there was no significant difference. Onishi concluded that the effect of the retrolaminar block, which was a double-level single-shot technique, was only effective up to 2 hours after surgery. So, what can be an explanation for a single-shot retrolaminar block being effective only for a short time, which is only around 2 hours? Actually, if you would look at the single-shot retrolaminar block, there was no difference at all as compared to the control group. One possible explanation can be derived from the study by Damjanovsky, wherein he showed that if you would inject a 10 cc volume of local anesthetic for the retrolaminar block technique, the local anesthetic would not spread to the paravertebral space, whereas if you inject a greater amount of volume, like 30 cc, there will be a spread to the paravertebral space. This is just one explanation. The theories that Damjanovsky gave for the diffusion of the local anesthetic towards the paravertebral space are the following: that the costal transverse ligament is a porous structure wherein the local anesthetic can penetrate towards the paravertebral space. The fluid tracks anteriorly through the looser tissues, just lateral to the facet joints. The dorsal ramus would exit at the medial aperture of the superior costal transverse ligament that can be a path for local anesthetic seepage. These explanations are also the explanation that Kostash gave for the block that he introduced, which he called the midpoint transverse process to pleura. This involves injection of the local anesthetic superior to the superior costal transverse ligament. Based from his cadaveric dissection, he was able to show that with the midpoint transverse passes to pleura, or MTP, there can be a spread to the paravertebral space, the sympathetic chain, and also the intercostal nerves. He would perform this technique in our institution. He would point the needle. You can see here the transverse process, and this one is the superior costal transverse ligament, the pleura. You point the needle just above the superior costal transverse ligament. Catangui introduced another form of block, which he called the rhomboid intercostal and subserratus plane block. This is a block which he showed through a cadaveric dissection that there can be spread of the dye towards the lateral cutaneous branches. It can also spread to the dorsal rami and the clavipectoral fascia in the axilla. There was, however, no extension to the intercostal nerves. This is effective not only for breast surgeries, but also for thoracotomy, rib fracture, and upper abdominal surgery. Based on the study that was done by Sitke, where he compared the Pecs from the rhomboid intercostal block, he was able to show that the effect of the Pecs block and the rhomboid intercostal block are the same. They have the same or similar effective analgesic effect. We have always known that the paravertebral block is the gold standard for analgesia for breast surgery. But a lot of anesthesiologists would avoid this technique because of its proximity to the pleura and because of its proximity also to the central nervous system and because of its concomitant complications. The paraspinal plane blocks that we have enumerated are better preferred by anesthesiologists because they are more simple techniques and they are almost devoid of complications. And they have been called by Costas as paravertebral by proxy. It is time to abandon the long-held belief that the paravertebral space needs to be directly accessed in order to achieve the spread of the local anesthetic to the thoracic nerve roots. It is actually an indirect way of achieving a paravertebral block. Dr. Chin, who is one of the front runners of the erector spinal block, mentioned that the maturation of the ultrasound-guided regional anesthesia has led to calls for the development of simple, safe, and reasonably effective techniques that are within the capabilities of most anesthesiologists. We believe that the ESP block represents a new and potentially exciting step in the democratization of regional anesthesia. So is erector spinae a magic bullet for postoperative analgesia? This is where I end my talk. Thank you very much.
Thank you very much, Dr. Penn, for this excellent overview of the interfacial plane blocks playing a major role for breast surgery. Now I will continue with my presentation, and I will upload it now. And hopefully you can see it now. And I will start now with my presentation. My name is Prof. Kessler. I'm from working in the University of Frankfurt in Germany. And I'm going to talk about today about the update of pediatric regional anesthesia. This is my conflict of interest, but this will not influence. I got honoraria from different companies, but this will not influence my presentation of today. I'm going to talk about these issues, the role of regional anesthesia and anesthesia frequency. What about the central peripheral truncal blocks? Which techniques do we use when we perform regional blocks in pediatrics? What about single and catheter techniques, safety and effectiveness? What about the complications? What about the additives to local anesthetics, test dose, is it necessary, and compartment syndrome? For a long time, we underestimate the pain in pediatrics, but we know now from many studies that the pain perception in pediatrics is similar to the adults. That means when we do not treat pain sufficiently, we will see persistent hyperalgesia, we see a reduced growth of body and brain, we see a poorer motor development, the newer endocrine and cognitive changes, and even we can see that we can provide an excellent analgesia regional techniques are not so suitable for regional anesthesia. This is only in special cases. We need less anesthetics, that is indeed. We can see a faster emergence and probably also we can see less emergence delirium in these patients. We can reduce the amount of opioids and non-opioids, and therefore we will see less nausea and vomiting and respiratory depression. And also we can provide an optimal post-operative pain control in these patients, which will result in a lower morbidity and a higher child and parent satisfaction. Unfortunately, there are not so many studies showing that there is an improved pain outcome when we compare regional technique with systemic opioids. There are only very few studies which show the evidence. These are peripheral blockades for eye surgery or intraorbital nerve blocks for cleft lip, inguinal or idiohypogastric nerve block for inguinal hernia repair, or the caudal block. Unfortunately, we have not so many randomized controlled studies in children which demonstrate that regional techniques are superior. And the reasons why we don't have so many studies are the barriers for recruiting patients in this age of group, and there is a lack of funding. There is no so big interest in the pharmacy or in the companies to support studies in children, because this is not the target group of these companies. And another important issue is that some of these drugs which we use for regional blocks in kids are not approved in this age group, and therefore the sum for the insurance is very high, and that's one of the reasons why we have not so many randomized controlled trials in this age group. But this is an overview of the current pediatric regional anesthesia practice. You can see we start with the head and neck blocks for ear and cleft palate repair. We see the thoracic epidurals, paravertebral or ESP block for thoracic and upper abdomen procedures, caudal block, tap block for infraumbilical, rectus sheaths for umbilical, caudal block, spinal for inguinal, genital, dorsal penile nerve block for penis, and brachial, the different form of brachial plexus for the upper extremity, and the typical blocks for the lower extremity that we all know from the adults, and for pelvic surgery, the LEA, lumbar epidural, lumbar plexus, quadratus lumborum. And of course, the surgeon should always do a local infiltration for post-operative pain relief. All blocks, but you should know all regional blocks that we know for adults are also possible for children, both as single and as catheter as well. Here are some examples of the not so common blocks. These are the superficial cervical plexus block for the greater auricular nerve for ear surgery or tympanomastoid surgery. Here is a lumbar erectospinal plane block for pelvic surgery. These blocks are usually easier to perform compared to adults because the distance from the skin to the target is not so far. This is an anterior quadratus lumborum block also for pelvic or for proximal femur procedures. This here is a paravertebral block for, this was a child with a scapular surgery, and also here you can see very nicely how the pleura is pushed downwards when you inject the local anesthetic. And here a lumbar plexus block, one of my favorite blocks in children. This was a very small baby, and these blocks are also to perform very easy because the visualization of the target is much more easier compared to adults. The question is, how often are these blocks now used, or which blocks are most common used in pediatrics? So we have a few big databases or multi-center studies. This here is the APRICOT study, the anesthesia practice in children observational trial from Europe, and you can see more than 4,000 regional blocks were included in this study. And these are the blocks which are performed. You see the difference in the country. Truncal blocks and also peripheral blocks were performed more frequently in Belgium and France. In which age were the blocks performed? You see the majority in the apricot study, the majority of blocks were performed in an age older than 1 and lower than 12 years. This is another big study from France, including more than 30,000 regional procedures. And you see here what you have seen before. In France, only 30% of all blocks were urexal blocks. Caudals account for more than 80%, and 66 were peripheral blocks. 60% truncal blocks account for the majority of these blocks. But what you can see, and what you can see also with many other studies, that over time there is a decline, a decrease in the urexal blocks. You see from 100% in 1990 to nearly 20 or 30% in 2010. And this is also confirmed by, this is the largest database regarding regional blocks we have. This is the PRAN database, the Pediatric Regional Anesthesia Network from US, started in 2007, and now included more than 100,000 blocks. You can see here with the green bars, this represents the urexal blocks, that the urexal blocks decreased from 75% in 2007 to nearly 50% in 2015. So another question is, which technique do we use when we perform regional blocks in children? Here, a few on the apricot study. You see here, landmark-guided were 72% of the blocks, and only 20% of the blocks were ultrasound-guided. But if you have a closer look to the landmark-guided blocks, you can see that more than 80% account for the central blocks and for the penile block. And if you look at the ultrasound-guided block, you can see most of the blocks of the upper limb, lower limb, and truncal blocks are performed with ultrasound guidance. And this data arises from 2004 and 2005, and the number of ultrasound guidance has increased over time. This is another analysis of the PRAN database looking at the caudal blocks. And this, you can see more than 18,000 caudal blocks were included, and 88% of all the caudal blocks were performed in landmark-guided techniques. And with this technique, this was a very safe technique. There were only 4 major complications and only 1 cardiac arrest. And the conclusion is that caudal anesthesia is the most common regional technique used in children worldwide. It is easy to perform with a landmark technique, and it provides a very excellent analgesia for surgeries below the umbilical area. But if you compare landmark-guided technique with ultrasound-guided technique, you will see that with the ultrasound-guided technique, you have a higher success rate and less complications. And I think this is very understandable, because when you do caudals in children without ossifications of the skeleton, you will have a very good view inside the tissue with the ultrasound. You can see here, you can see in children up to 1 to 3 years, the test dose. You can see the upper spread of local anesthetics. And if you advance a catheter, you can follow the catheter very well. Here is an example for an ultrasound-guided caudal block. You can see how the local anesthetic is injected, and you can see also the needle here placed for the caudal. But nevertheless, we must concentrate that the block of choice, the standard of care when you do a caudal block, is the landmark-guided technique. What about when you do spinals or epidurals in children? What is the role of ultrasound? And here, we have the same what we have seen for the caudals, because the ossification is not yet finished. So we have a very good tissue, a view into the tissue, and we can visualize the ligamentum flavum. We can even visualize the dura here, the intrathecal space, and we can measure the distance from skin to the dura. And comparison with ultrasound-guided blocks showed that with ultrasound-guided, you can measure the distance to the epidural space in every adults. You can see the conus medullaris, and you can follow the lumbar or the thoracic catheter into very small kids. Here you can see in real-time epidural puncture in a child with 30 kilograms. It's a paramedian sagittal optical scan, and you have a very nice view to the epidural space. You see the ligamentum flavum, you see the dura, and here a short video. The needle is advanced here. The upper line, this is the ligamentum flavum. The line below is the dura. You see, we are now touching here the ligamentum flavum. Now the needle penetrates the ligamentum flavum, and the local anesthetic is injected, as seen here by the depression of the dura here. But the real-time ultrasound-guided neuroaxial block is not a standard of care. It's only possible to see this in very young children. The technique when you use ultrasound is rather an ultrasound assisted than an ultrasound guided. Before you do your puncture, you use your ultrasound, you detect the interspinal space, you do a mark, then you place the probe in a sagittal way in the midline, and you mark also the midline with this line. Then you put the probe away in the intersection of both lines. This is the place where you do your epidural conventionally. So the standard of care for epidural and spinal in children is the landmark guided technique. You can use ultrasound, but only in an assisted way. Helpful is ultrasound when you have an abnormal anatomy. For example, when you have a child with scoliosis and you have a rotation of the spine, then you have to tilt the probe until you have the spinous process perpendicular in your probe, and then you can measure the angel from the midline, and then you have to advance. You put the probe away, and then you can advance your needle according to the angel that you measured before. So you can use ultrasound as a pre-scan or ultrasound assisted. What about ultrasound and peripheral nerve blocks, or when you do truncal blocks? Is ultrasound helpful in these blocks? Of course, here you see again data from the PRAN database from 2012, and already in this publication you could see that for upper extremity, lower extremity, and truncal blocks, the use of ultrasound was between 60 and 80%, and this percentage has increased over time. You see here the increasing use of ultrasound could be demonstrated for nearly all kinds of blocks, upper extremity, lower extremity, head and truncal blocks, except for neuroaxial. You see neuroaxial, this is the gray line parallel to the X here, and there is no change and no increase over time. But especially for peripheral nerve block, you can see here the increasing use of ultrasound. In 2007, only 25% of the blocks were performed with ultrasound. Now we are really at 90%, and that shows us that ultrasound is the new gold standard for performing peripheral nerve blocks in children. So ultrasound has also increased the use of peripheral regional anesthesia in children, because nearly all of the new truncal blocks are only possible with the use of ultrasound. What about dual guide? That means, what about the addition of another method to nerve detection, such as nerve stimulation when we use ultrasound? This is a technique we are commonly used in adults when we perform deep blocks, for example, proximal sciatic or lumbar plexus blocks, or when we have a steep puncture angel because the visualization of the target and the needle is impaired, and then we are very happy when we have the nerve stimulation to detect the nerve. This is not so the case, I think, in children, because the distance to the target, to the nerves, is very small, a few millimeters up to a few centimeters, and nearly in all cases we can use a linear probe, and the use of, or the additional use of nerve stimulation is probably only necessary in some of the proximal sciatic or lumbar plexus blocks. Now we have seen that our new comparative data comparing ultrasound with nerve stimulation or landmark shows us that with ultrasound, we have a higher success rate and we have a lower complication rate. And this is confirmed in this Cochrane review, including 33 trials and more than 2,000 patients. And when we look at the efficacy, you can see that the success rate is increased by 20%. With ultrasound, the duration is increased by 40 minutes, and the pain score are decreased for at least 1 hour after surgery. What about the safety issues? The safety issues are not so convincing. It shows us that there is no so big difference with ultrasound compared to nerve stimulation, but the reasons for that are clear. First of all, we have already with nerve stimulation a very low complication rate, so it's nearly impossible with only 2,000 patients to demonstrate that ultrasound would be superior to nerve stimulation. You see it here, there are no major complications occurred in this Cochrane review. And we know that the rate of transient neurologic symptoms is not different between nerve stimulation and ultrasound. The reason for that is that this ultrasound is still a relatively new technology, and it's not so easy technique, and some of our colleagues have a problem to align the ultrasound beam and the needle, and that's the reason why some of us advance the needle without visualization, the needle tip, and that's the reason why we produce a lot of paresthesia when we use ultrasound, which is always a lack in competence. For me, one of the biggest advantages of ultrasound is the reduction in volume of local anesthetics when we perform nerve blocks. Compared to landmark or nerve stimulation, we can reduce the volume with ultrasound by 40 or 75%. And this is absolute a big success. On the other hand, when we do facial plane blocks, we see no reduction. And for some of my colleagues, the ultrasound-guided facial plane blocks is a step back because we need a huge amount of local anesthetics, and local anesthetics can be harmful in this group of patients because the pharmaceuticals. First of all, until the second year, the myelination is incomplete. That means we need lower concentrated local anesthetics. The cardiac output increase, which results in earlier and higher plasma concentration, plasma levels. On the other hand, the volume of distribution is also increased, which results in lower maximum plasma levels. The immature liver function results in a reduced protein binding, especially by a reduced level of the alpha-1 acid glycoprotein, which means that the free rate of the local anesthetics is increased, and the decreased hepatic flow and renal clearance can lead to an accumulation, where, especially when you have catheters and you have a continuous infusion. So we must be very careful regarding the volume of local anesthetics in small children. And that's why some of our colleagues advocate that the use of ultrasound guide is strongly recommended when performing peripheral nerve blocks in small children. When you perform blocks in these age of groups, you should also know the maximum recommended dosage, which are possible in these groups. You can see here on this list maximum doses for single shot and for infusion as well. But these maximum recommended doses are completely different to that what we should use clinically. And these are the clinically recommended doses from expert panels from the American and European Society of Regional Anesthesia. And for example, if you look at the ropivacaine, you can see the usual clinic dose is much more lower compared to the maximum doses for single shots and for infusions as well. And I will point out in the beginning, when ropivacaine was introduced in clinical practice, it was much much more expensive than bupivacaine, but for more than 10 or 15 years, ropivacaine is available as a generic drug, and from that time on, the difference in prices and the costs are not so big. And for me, there is absolute clear recommendation for using ropivacaine and not bupivacaine in small children. Also important is to know, is this drug approved in this age of group? And you see here the approval list for Germany, and this approval list I think is different from country to country, but you can see here nearly none of the local anesthetics is approved for the newborns. Usually the approval starts with 6 months, or for most of them after 1 year. And if you're doing blocks in kids younger than the approved date, you should inform the parent, and you should have the informed consent written or verbally from the parents when you do blocks in these very young children. Local anesthetic systemic intoxication is a real issue, and you can see here from the PRAN data bank, the incidence is 0.75 per 1,000. It was unchanged over time. This rate is lower compared to adults, but when you look at the very youngs, you see the incidence is higher, because in this database, 7 cases of severe intoxication occurred, 6 after a neurexor block, 1 only after peripheral nerve blocks. And there was a clear risk factor, age younger than 6 months. This was a clear risk. And you can see in 5 of these cases, bupivacaine was used. But the good news is that intralipid is also helpful in these cases. And there are a few case reports where when intralipid was used, you see here 4.9 kilo baby for a caudal, and a 3.2 kilo baby also for caudal, both with bupivacaine, but intralipid was used successfully. Another issue or controversial discussion arises: should we do the regional blocks in an awake or a sleep patient? Those who support to do the blocks in an awake argue that in an awake patient or child, you can monitor, you can use the child as a monitor. When you are close to the nerve and you touch the nerve, the child will feel a paresthesia or pain. This is not the case if the patient, if the child is asleep. On the other hand, those who advocate you should use it in a child after general anesthesia advocate that an uncooperative child would harm the performance, because there is an uncontrolled movement, and you can touch with the needle the nerve by this uncontrolled movement. But I think this question has been adequately answered now. But this question arises many years ago, nearly 20 years ago, when there were some reports of spinal cord lesions after an epidural under general anesthesia. This is by Bromwich, and also the same spinal cord lesions after an interscalene block performed under general anesthesia. And these 4 cases with interscalene blocks, they are also done with the Winnie technique, with the medial approach of the nerve. There are other approaches like such that of Meyer. When you advance the needle more laterally, it's nearly impossible to touch the spinal cord. But the conclusion of both are that you should not do an epidural at the level of the spinal cord in an unconscious patient. And the same also in his editorial, he stated that an interscalene block under general anesthesia must be exception. And based on this publication, the American Society recommended that interscalene block should not be performed in anesthetized for heavily sedated adults or pediatric patients. This was the death of any interscalene block in that area. But an analysis published a few years later from the PRAN databank showed that an interscalene block performed under general anesthesia is safe. You see here is a serious complication, no LAS, no PONS, no cardiovascular complication, or no punctural dura puncture. And the same could also be demonstrated for all the blocks in the database, in the Brand database. 94 were performed under general anesthesia. And you can see here the rate of post-operative neurological symptoms were under general anesthesia 0.9 per thousand, and it was 6-7 times higher in the awake or sedated patients with a rate of 6.8. And the same could be demonstrated for the incidence of intoxication under general anesthesia, 0.08 in the patients with general anesthesia, in 5 times higher in the awake or sedated patients. And the reason for that is very clearly when you, under general anesthesia, the general anesthetics which are used for general anesthesia, for example, propofol, will increase the seizure threshold. So this is a beneficial effect. So you see fewer rates, you see fewer seizures when you perform these blocks under general anesthesia. On the other hand, you will mask with general anesthesia the first signs of intoxication, such as seizure. And when you see signs of intoxication, so the signs that you can see are the hemodynamic signs or the cardiac arrest. But from these data, the recommendations from the expert channels from ASRA and ESSA was that peripheral regional anesthesia under general anesthesia, that deep sedation is standard of care. So in our institution, we perform in children younger than 6 or 8 years. Usually we use a general anesthesia or deep sedation, and in children older than 6 or 10, we do an individual approach, case by case. It depends also on the block location. For peripheral nerve blocks on the lower limb, maybe we can use it in the lightly sedated, but for blocks of the upper limbs, for an interscalene block, for example, we prefer to do it in a patient under general anesthesia. And if we look at the ERECTOR study, you can see these more than 4,000 blocks. There were no case of intoxication, no case of nerve damage, or no case of death. But the number is also with 4,000 too small that we could demonstrate with this small group any kind of serious complication. The French group, when you look at the complications here, you can see a low complication rate. The complication with under peripheral nerve blocks was 6 times lower compared to neuraxial blocks. And for the neuraxial blocks, the complication rate was higher in children younger than 6 months. And the Brand database, you have seen before, no case in more than 100,000 patients, no case of permanent neurological deficit, a low rate of post-operative neurological symptoms. The intoxication rate was lower compared to adults, but it was higher in the young, very young children. Respiratory depression occurred only after neuraxial blocks, but also very rare. And the dural puncture also occurred, but also it was rare under caudal, and the highest rate was found after lumbar puncture. So the summary regarding safety issues when we perform pediatric regional anesthesia is that we see overall a very low complication rate. We see a lower complication rate with peripheral blocks compared to neuraxial blockades. We have a higher complication rate in newborns and infants, and there is a trend away from neuraxial to peripheral blocks. And my forecast is that the use of neuraxial techniques will decrease. And an example for this changing role of the block techniques I will show you in inguinal hernia repair. You see here, this is a meta-analysis comparing caudals with other regional blocks with the ilioinguinal, iliohypogastric, TAP, or quadratus lumborum. For all of us, we could see a very good pain relief, and pain relief was equally between all these different techniques. But for ilioinguinal, we need a lower volume. For TAP and quadratus, we need, again, a higher volume. But and older children, probably for uni and bilateral inguinal hernia repair in the future, the iliogastric block or probably the TAP or the QLB block will be in choice, but for TAP and QLB, we have not enough data yet. When should we use catheter, or should we only use single shot in kids? I think there are some real indications for catheter. For example, if we have if kids undergo surgeries with moderate or severe pain, for example, major thoracic, abdominal, or bone surgeries, or oncological surgeries, for physiotherapy after major limb surgeries, or patients with chronic pain syndromes. When we look at the database, we see that in the French study, the amount of catheters were 9%, and in the PRAN database, 24%, and new axle procedures, new axle catheters account for the biggest numbers of catheters. Complication, when we look at the complications, the most common complication was malfunction due to dislocation or disconnection, which resulted in the prematurely removal of the catheter in 70.5%. The second most common reason was mild infections, no serious, no new axial hematoma occurred with catheters, but only one hematoma after by a PVB catheter, and one catheter was placed intraperitoneally. And the data from France and from other studies looking at the complication rate of catheters, you see the incidence of complications is about between 10 to 50, 25, but the most common case in all studies is dislocation. What also the study shows that we can see a decline for many blocks over the time in the rate of complications, and we can see that we have a higher incidence of complications can be found with new axial blocks. When we use catheters, how should we use catheter? In our department, we only use patient-controlled systems, and we use it not as a patient-controlled system, but we use it as a PCA, that means parent-controlled analgesia, or NCA, nurse-controlled analgesia, in the very small kids, and it works very fantastic. Another issue is what about additives to local anesthetics? Does it make sense to use this, and when should we use it? Here you can see some fundamental requirements which should be fulfilled when you use additives. There should be given approval of this additive. There should be in randomized controls really beneficial effects. There must be the mechanism of action should be well known, and the side effects profile should be tolerable, and these drugs should all available as a preservative-free preparation to reduce the amount of allergic reactions. And this can be expected when we add additives to local anesthetics. We can only extend the block duration, and that means we extend not only the analgesic effects, but we extend also the motor block. There are no additives which separately only increase the duration of the analgesia, but not of the motor paralysis. We reduce the need of anesthetics, and we can achieve a smooth emergence from anesthesia. And because we have a longer duration of block, we can send free the patients pain-free. But you cannot expect, and these are additives not unable to do a higher success rate. If you have a not well-working block, you cannot expect that you will increase the success rate when you add some adjuvants. Here, these are the adjuvants which are commonly used or to local anesthetics. Those ones on the right side are not those ones which should be used in kids. On the left-hand side, these are additives where we have a few publications or many publications. For glucocorticoids such as dexamethasone, there are enough data showing when we add on to a caudal, we can increase the duration of the caudal up to 4 hours. We have meta-analysis when we add alpha-2 agonists, dexmedetomidine or clonidine for here on the left side to caudal anesthesia, which will result in an increased duration of up to 8 hours. And for caudal anesthesia, and when we add the alpha-2 agonist to peripheral nerve blocks, we can see we can increase the duration of the block up to 6 hours. So the recommendation of the experts regarding the additives is that for adjuvants, we have no approval for peripheral nerve blocks. We have an approval for morphine when we give it neuraxially. And we can also give neuraxal even if we have no approval clonidine or morphine. Clonidine can also give caudals, dexmedetomidine. The use of dexmedetomidine is possible. For dexmethasone, I mentioned before, there is no recommendation. You should do this intravenously. And for peripheral nerve blocks, dexmedetomidine seems to be an option. What about the addition of epinephrine to local anesthetics to detect if we inject, if we have an intravascular injection by looking at the ECG, at the heart rate or the changes of the T wave? Is this an option? There are some problems with the interpretation in these young children because the heart rate, the basal heart rate is already very high in these patients, and to see a change with epinephrine is sometimes very difficult. There is an age-dependent variation in reactivity of the cardiovascular system, and we also have influence by our general anesthetics or by general techniques. For example, if we compare a total intravenous anesthesia with a balanced anesthesia, this also will influence the heart rate, and this makes it much more difficult compared to adults if we have an intravascular injection or not. And therefore, the recommendations of the ASRA and ASRA is test dose should remain optional if you want to use it or not. We have a lot of false negative results, but if you do an injection of local anesthetics peripherally or caudally or neuraxially, you should do it also very slowly in small aliquots and to wait and see what happens. And any modification of the T wave or the heart rate within 30 to 90 seconds after injection should be interpreted as an accidental IV injection. And if you do peripheral nerve blocks ultrasound-guided and you don't see the spread of local anesthetics when you inject local anesthetics, it should also be interpreted as an accidental IV injection. What about when we do an epidural? Should we use air or should we use saline for the loss of resistance technique? Again, the recommendations from the experts is that we, up to now, we have insufficient data to differentiate, to say this technique, the one technique is superior to the other technique. So you can use air or saline for loss of resistance safely. But I think the best option is if you do a combination of a little bit air and saline when you do an epidural puncture. So you will minimize the risk of injection of air, and you can reduce the volume of saline when you use a combination of both. And finally, what about compartment syndrome? There's also a huge discussion among surgeons that we will mask with our regional early signs of acute compartment syndrome, and this is severe pain or hypoesthesia. Risk for compartment syndrome are operations of the tibia or intramedullary fixations or operations with a long duration. The symptoms are severe pain, hypoesthesia, or if you have to increase your analgesia. But again, the recommendation is that there is no current evidence. There's the use of regional anesthetics will delay the early signs of diagnosis of an acute compartment syndrome in these patients. But the kind of additives, you should monitor these patients very properly and if possible, you should use some some compartment pressure measurements, if possible. So my last slides summarize these things. How can I successfully perform a pediatric regional anesthesia? First of all, you should use an ultrasound machine. If you have no ultrasound machine, it's not available, you can do, of course, these blocks with nerve stimulation. When you use ultrasound, you should use an adequate equipment. That means you should use, for the small babies, a hockey stick. You should use smaller needles and shorter needles and smaller catheters compared to adults. These needles and catheters are all available. What is important is you should have expertise in ultrasound. And for me, one of the major reasons why the complication rate is lower in children compared to adults is based on the fact that regional anesthesia in children is only performed in those colleagues of us who are experts in ultrasound in adults. Education and training, of course, is very important. If you want to implement such regional techniques in your department, you should concentrate on a very few effective blocks. Here, this is a list of some blocks which will cover many or nearly all the operations: axillary plexus block, caudal block, epigastric tap, femoral nerve blocks, proximal or distal sciatic blocks. But the blocks you would prefer should be adapted to the surgery, to the operations, which are done very often in your department. Here, when you are as in our department, our orthopedic department, where we are specialized on many different operations. So we have the standard operating procedures for many operations, nearly for every kind of operations in kids. We have different recommendations. You can see here for pelvic osteotomies, the triple osteotomy is a very big pelvic surgery. The first recommendation is a lumbar epidural catheter. Second, or alternatives are quadratus lumborum, a psoas compartment, or femoral nerve block. Here you can see for epiphysiodesis of the proximal femur, a femur block; for knee, a femoral triangle block; for pelvic or arthroplasty, it's a lumbar epidural; for proximal femur, epiphyseal capitis femoris is a psoas compartment catheter; for corrective osteotomies from the femur, a femoral catheter; for the tibia, distal sciatic block; for the proximal tibia, femoral block; club foot. There also exist many different operations. For minor operations, we perform a foot block. For major operations, we perform a proximal sciatic catheter or nerve block. But you also have to organize and to manage the time and the staff. You must be aware, if you do blocks in children, you do these blocks usually after general anesthesia, and that means that the anesthesia-related time is increased compared to general anesthesia only. This you have to keep in mind, and the best way, if you do these blocks, you have a second team, or you can do also these blocks after the operation, but all that this increases the operation time, and this is not so easy to manage. You have to deal this with the operation and with the operation manager, how you perform or how you can implement a regional anesthesia program in your department. So I will summarize. The update on pediatric regional anesthesia is that regional anesthesia, I hope I could demonstrate, offers many advantages over systemic opioids. Regional anesthesia in infants and children is safe and shows a low complication rate. Ultrasound makes regional anesthesia safer and more efficient and increases the acceptance of patients and parents. There are many easy-to-learn techniques which can be implemented in any department, and landmark technique is still. No. Hopefully, I can stop. And now I hope we have enough time for question and answer. So I look at the question and answer block, and here is one question for Dr. Penn. Which block is best to do for an upper abdominal surgery like gastrotomy? This was not the issue of your presentation, Dr. Penn, but maybe you can give an answer.
Yes. My topic is actually on breast surgery analgesia, but based from our experience in my institution for upper abdominal surgery, we actually have several choices. First, we would do erector SPINAE bilateral plain block for such type of a surgery. Second, we can also do a top block, but it depends on the incision. If it is midline, then we would do a rectus sheath block. Third, we also do an TQL or transmuscular quadratosum block. Based from the observation that we see among patients when we perform these blocks, we would notice that the TQL block is better as compared to the erector SPINAE or the lateral top. Maybe there can be other reasons, but as of now, that is what we have been trying to observe.
Yes, I would also like to add that depends on the kind of surgery. It's a minor surgery or it's a major surgery. And I think the major advantage of all these fascial blocks you also presented is that you can use it because of the low risk profile. You can use it also for minor surgery, for surgery where you would never use any kind of new axle blocks.
Yeah.
Second question is also addressed to you. Questions, what blocks and dose and concentrations would you use for surgical anesthesia for breast surgery? I think the topic of your presentation was analgesia. What kind of analgesia can I achieve with the fascial plain block? But are these blocks also candidates for a surgical anesthesia, or should I add it always with a general anesthesia?
Yes, actually, these fascial plain blocks that I mentioned, whether anterolateral or paraspinal, is all meant for analgesia. But if you would push for anesthesia, then you would rather do a paravertebral block. Because a paravertebral block, if you can see it as a sympathetic blockade effect, you are directly injecting your local anesthetic to the paravertebral space where your intercostal nerve is located. But I would suggest that if you're going to use it as an anesthetic, you would rather do it at 3 levels, like you would inject, because your breast is actually innervated by the lateral cutaneous nerves and the anterior cutaneous branches from T2 to T6. So we observe that if we do a one level technique for paravertebral and they would reach to the point of doing an axillary lymph node dissection, we can see that the gas concentration or the heart rate of the patient would increase. So we can see that we also need to block that level that is nearer to the intercostobrachial nerve, which is actually the T2 branch of the lateral cutaneous. So if you would do it as an anesthetic, it would be best to do 3 levels, T2, T4, T6, at around 4 cc. If you would look at the lectures of Dr. Karmakar, he would advise 4 cc each level of 0.5% bupivacaine or ropivacaine. But if you would choose a 2-level technique, then you can add more volume. Maybe you can do a level of T2 or T4, T5, T2 and T5. Maybe place 10 to 15 cc of volume of 0.5% ropivacaine or bupivacaine. So,
can I add another question to this point? You have shown that the innervation of the breast is also performed by the pectoral nerves and
yes,
also long thoracic nerve, and also when you do a lymph dissection. This is not necessary for complete analgesia when I will avoid a general anesthesia. Add to my paravertebral block any kind of brachial plexus block, or is it not necessary? And even the supraclavicular nerves from the cervical plexus innervates the skin over the breast surgery. Is this necessary or not, or it depends from case to case?
You are very right that the other parts of the breast, like the pectoral muscles, are innervated by the brachial plexus. But the way I see it, if you perform a paravertebral block in all of these 3 levels, because we have one workshop wherein Dr. Karmakar actually did it. So he did 3-level technique for breast surgery, and it was done, but with adequate sedation, like you have to add propofol and remifentanil along with your block. So that is based on what I've seen in one of our workshops with Dr. Karmakar, but personally, in our hospital, I haven't done performing paravertebral block alone for breast surgery as an anesthesia. So what about Dr. Kessler? What is your experience? Have you done paravertebral block alone as an anesthesia for breast surgery?
Unfortunately, I'm not so familiar with the breast surgery. This is not my major topic, so I cannot really answer these questions. What kind of block is the best for breast surgery in peripheral blocks only? So unfortunately, I cannot answer this question, sorry. But we will continue look at the question and answer section. Here's a question for me. Does BIS monitoring help detect seizure in pediatric patients under general anesthesia receiving a Richard block? Also, I have no data on this, so I cannot answer this question, but probably it's an option which can be used to detect seizures in patients when you don't see when the seizures are masked by general anesthesia. And this is also, I can at some point, when you do it in an awake patient and you see the first signs of seizure, so you will immediately stop with the injection of local anesthetics. And this is not the case when you do a block under general anesthesia and you don't see the first sign of seizure, you don't see these signs, then you continue to inject. And as I mentioned before, probably you see only the cardiac signs of intoxication. That means cardiac arrest. So I don't know if to do the block under general anesthesia, if this is protective or not. But what we can say from the data we have, that the rate of seizures is slower or is lower compared to when you do it in an awake patient. Next question. Does it matter if the dexamethasone is given together with the local anesthetics versus intravenously? You can give it intravenously, then you have extension of the block, but we know from data that the extension is increased when you give dexamethasone perineurally. But perineurally is not approved, and I would be very careful when I add additives in children, small children, because of the pharmacokinetics and the nerve system. So I would prefer, when I use dexamethasone, to give it intravenously. Next questions. Do you use the caudal block before or after surgery? When we do a caudal block, we usually in our department do it before we do the block. I don't know, what is your experience, Dr. Penn? Do you do it before or after the surgery? What is your usual practice?
For the caudal block, you would usually, you can do it after the patient has been intubated or the experience
after the surgery, or if you do it before the surgery or after the surgery. This is the question.
Before the surgery.
Yes.
Yes.
We do it also before the surgery. But you can do it, but also after the surgery. I think for me, it doesn't matter. And if you do it after the surgery, probably you have a longer effect on the other side. When you do it before the surgery, you have an intraoperative effect and you have an opioid sparing effect. Catheter or single shot when you using, or what are you using?
Okay, so for breast surgery, There are actually several choices again. I think it will depend also on your comfort, on the level of comfort, on the type of block that you can perform. So you can actually perform all the blocks like erector spinae. You can do a paravertebral block. You can do a Pecs block, Pecs 2 block, or you can do a Serratus brain block. But we noticed that if you do an erector spinae block at one level, if you put it at T4, we noticed that during the axillary lymph node dissection, there's usually an increase in heart rate and blood pressure of the patient. So I would suggest that if you don't want that to happen, although postoperatively, you can see that these patients have a VAS score of only around 1 to 2, even the day after surgery would add adjuvants like dexamethasone. So you can actually manage even if you just inject your local anesthetic at the level of T4. But I think if you want more, like if you don't want these things to happen, like there's an increase in blood pressure when the axillary dissection is being performed, then you can do perhaps 2 level of blocks for erector spinae, that like doing it at level of T2 or T4 and or T2 and T5. The same with Pecs 2. With Pecs 2, we would usually do it after the surgery is done, before we extubate the patient, because if they have a breast mass, they are usually in pain, and if you will place your probe at that area of the breast at the level of rib 3 or rib 4, then it will be at the discomfort of the patient. And besides, you have some surgeons who would complain intraoperatively of some fluid in the area of the pectoralis major muscle or pectoralis minor muscle. So we would usually do our Pecs 2 block after the surgery before we extubate the patient. And you still have a very nice postoperative analgesia, whether it's erector spinae or Pecs 2 or even for serratus plane. For serratus plane, we would also do 2 levels, like putting it at rib 3 and rib 5, because if you would put it at a lower level, then there will also be pain during the axillary or after the surgery at the area of the axilla, because you cannot cover that area for the axillary lymph node dissection. Now you can also opt to do a paravertebral block. So it will all depend on you, on your level of comfort and how you see these blocks working on your patients. So
thank you very much. Yes, this was very good explanation and answered this question. Thank you very much. We are a little bit over time, so we have 3 small questions, and then I will give back for the final remark to Jensen. One question is a sciatic nerve block, the Labat approach, effective for lower limb pediatric surgeries? Of course, you can use it if you have a lower limb procedure. The next question, hemidiaphragmatic palsy following above clavicle blocks in pediatric. Is this a big concern? I think hemidiaphragmatic palsy will occur when you do an interscalene block, for example, but it is without, to my experience, without any clinical relevance, because the kids are usually not impaired regarding breathing. And the last question, do you use elastomeric pumps for continuous infusions for peritoneal catheters for pediatric patients? I have no experience with elastomeric pumps. When we use catheters, we only use it for inpatient, and then we only use reusable pumps. But I'm convinced in US, where a lot of or many of these procedures are doing in outpatients, they also send home kids, pediatric children with elastomeric pumps. So I think I would thank the audience for the many questions. I would also thank Dr. Cano for the excellent presentation, and I will give back to Wisonic, to Jensen for the final remarks. Thank you very much.
Thank you. Thank you, Dr. Kessler.
Thank you, Professor Kessler and Dr. Pen. It's really appreciated for your impressive sharing today and the coming webinar at the end of this month. So it's been a pleasure being with all of you today, and we wish we hope to see you soon. Thank you, Professor Kessler and Dr. Pen.
Thank you. Thank you very much. Thank you. Thank you.
Thank you, Dr. Kessler. Thank you, Jensen.
Thank you, Dr. Khan. Thank you. Thank you. Thank you.
Thank you.
Goodbye.
Bye-bye. Bye-bye.
Bye-bye.
Hope to see you next.
I really hope that we can have the watchers in China in the coming future.
Yes, hopefully. Okay.
Yeah, hope to see you in Shenzhen.
Yes, okay. So have a good night. Have a good night.
Have a good day. Goodbye.
Bye-bye.
Record.